This is the second part of pediatric physical examination. In this part, I will discuss on examination of H.E.E.N.T, head, eyes, nose, and the throat. To examine the ears, throat, and the mouth, the parent should restrain the child in a sitting position. This examination should preferably be done at the end of the rest of the physical examination. To start from head, when we examine the head of the children, examine the size and the shape of the head. The size of the head is measured as described above. However, grossly one can see microcephaly or big macrocephaly. If the head is big, transillumination should be done in a dark room. Because we have discussed about measuring the size of the head on the physical examination part 1 by head circumference, but grossly without measuring the circumference of the head, we can say small head or big head, microcephaly or macrocephaly, without measuring it. And if the head is big, transillumination should be done in a dark room. There are different shapes of the head. For example, frontal bossing, which is a protuberant enlargement of the frontal bones, or caput caruratum, which is a box-shaped head, can be seen in a child. Both of the above deformation, both frontal bossing and the caput caruratum, is common deformation in our setup because of the rickets. Rickets cause frontal bossing and the caput caruratum in children. So even examining the shape of the children, the shape of the head of the children will give us a clue to the diagnosis of the rickets. Then size and the character of fontanelle should be seen. Note the size and the character of fontanelle, and only anterior fontanelle should remain open after 2 weeks, and the anterior fontanelle measures 2 by 4 centimeters for the first few months, and it should be just the size of the fingertip at 1 year. The anterior fontanelle closes between 10 to 18 months of age, and open fontanelle after 18 months could be due to increased intracranial pressure, or it might be due to rickets or hypothyroidism, osteogenesis imperfecta, or subdural hematoma can cause open fontanelle up to more than 18 months of age. So checking the size and the character of the fontanelle is important. And also check for the possibility of early closure of the suture lesions. The cranial sutures are open during a newborn period, but should be closed thereafter. At times, there could be an early closure of the suture where the suture lines feel hard and raised. That's called craniosynostosis. To differentiate craniosynostosis from molding, in molding we can separate by pushing the overlapped bones, whereas in craniosynostosis that is not possible. And also feel for craniotapes, which is a feel of indentation when a table tennis ball is pressed with fingers, and it is found by pressing firmly in the temporoparietal or parieto-occipital areas of the scalp, and it indicates softening of the skull. So if there is a craniotapes, that means indentation when we press the bones around temporoparietal or parieto-occipital area. It might show disorder like rickets, hydrocephalus, syphilis, osteogenesis imperfecta, and the premature infantis. And also palpate the skull carefully for areas of tenderness, and there might be areas with defect in the skull, as in the case of encephalocele. When we see the eyes, examining the position of the eyes, lids, conjunctiva, cornea, and the pupil is important. Look for vision, microphthalmus, exophthalmus, strabismus, nystagmus, xerosus, keratitis, bitoid spots, ptosis, setting sun appearance, ectopia lenses of Marfan syndrome, and the cataracts, which might be due to congenital rubella syndrome. They can all seen be on the examination of the eyes. And due to the thinning of the sclera, the eyes might appear blue in children with osteogenesis imperfecta and Ehlers-Danlos syndrome. So if a child have a blue eye, we might have some differential diagnosis even by inspecting the eye. It can occur in case of osteogenesis imperfecta and Ehlers-Danlos syndrome, and also other disorders. That is due to a thinning of sclera. It causes bluish appearance of the eye. And examine for interpupillary distance. Normally, the interpupillary distances range from 3.5 to 5.5 centimeter. But if there is interpupillary distance greater than 5.5 centimeter, we call it hypertelorism. That is a wider interpupillary distance due to enlargement of the laser wing of sphenoid bone, and it might be associated with midfacial anomalies and also mental retardation. The other thing is we should have to also examine the conjunctiva, whether it is pink, pale, or whether there is any signs of discharge. And also, as we have said, we should have to examine the cornea and the pupils. Pupillary size is also important. Example, in comatose child, we can see different pupillary sizes, and we can put our differential diagnosis by even examining the size of the pupils. The other is examination of the ears. Examine the shape, size, and the position of the ear. Ears are low-sit when the tragus of the ear is below the level of the outer canthus of the eye, and look for discharges from the ears such as pus or blood, and feel for swelling and tenderness of the mastoid process by palpating behind the ears. So if there is ear is normal, we can say no abnormal size, shape, and the position of the ear. We can say no visible ear discharge, and also we should have to check tragus and the mastoid tenderness, and if it is normal, we can say no tragus or mastoid tenderness. And the next one is examination of the otoscopy. Look for tympanic membrane light reflex, check for hyperemia, check for bulging, and also check for perforation. A bulging blue-red tympanic membrane may suggest basal skull fracture due to accumulation of blood in the middle ear. So, after examining the shape of the ear, the size, the position, any discharge from the ear, and also any tenderness of tragus and the mastoid, we should have to complete our ear examination by doing otoscope. The next one is examination of the nose. Examine for shape, patency, discharge, nasal symptom, and whether it is deviated or whether it is normal, and also press over the maxillary sinus and the frontal sinuses to check for tenderness of the sinuses. Normally the ethmoidal, sphenoidal, and the maxillary sinus are present at birth, but the ethmoidal sinus does not develop until 4 to 6 years of age. So if our examination of the nose is normal, we can say intact nasal septum, if midline, and also if there is no discharge or no polyp, no visible nasal polyp or no visible discharge, and also we should have to feel for any tenderness over the frontal sinus or maxillary sinus, and if it is normal, we can say no tenderness over maxillary and frontal sinus. The next part of H.E.E.N.T examination is mouth. On the mouth, we can check for lip color. For lip color, for example, we can see cyanosis or pallor. We can check for presence of cleft palate, any cracked lips, any ulceration, and also should have to check a tongue for protrusion of tongue, deviation of tongue, color, papillary atrophy, any trash, any oral trash, any dryness, and also you should have to check mucous membrane for any coplic spot, and also we should have to check a teeth for any caries, any gamma hypertrophy, or any number of teeth that's present, and also we should have to count the number of teeth that is there. And milk teeth are started to erupt at around 6 months of age, and the eruption of 20 milk teeth is usually expected to complete at 2 to 3 years of age. And the permanent teeth eruption starts around 6 to 7 years, and delayed dentation might occur in rickets, cretinism, and Down syndrome. So we say delayed teeth eruption if there is no any teeth up to the age of 13 months. So up to 13 months, there is a possibility that there might not be tooth eruption, but the normal expected time is 6 months of age. So we define delayed teeth eruption if it is if there is no teeth at the age of 30 months. So if there is delayed dentation, we might consider the cause as rickets, cretinism, or Down syndrome, or any other thing. And also we should have to check the color of the teeth. The color of the teeth may become brownish due to fluorosis, which is common dental problems in our country, especially in the Rift Valley areas. But nowadays it is corrected, and also tetracycline is now rarely used, and it also causes dental discoloration when it is used in children under 7 years of age. And also, in addition to lip, tongue, and the teeth, in the mouth, we should have to check for pharynx, and if there is hyperemia, swelling of tonsils, and if there is any exudate on the tonsils, we should have to check it. So if everything is normal in the mouth, we can say no cleft lip, cleft palate, wet in the pink tongue and the buccal mucosa, no dental caries, no gamma hypertrophy, pharynx is normal, and the like. So we should have to check lip, tongue, teeth, and the pharynx in the mouth. Thank you. Don't forget to subscribe for the next. On the next lesson, we will talk about the respiratory system physical examination and the others.